Section 1. Two worlds. One mind. The common confusion. We hear these words whispered. Bipolar. Schizophrenia. They surface in news stories, hushed family conversations. They carry the weight of fear and misunderstanding. For many, these terms blur into one another, creating a confusing landscape of mental illness. People often mix them up. They imagine a single, chaotic state of mind. This confusion is understandable. Both conditions can profoundly alter a person's life. Both can emerge in the vulnerable years of young adulthood. Both can lead to behaviors that seem bewildering to the outside world. This essay will draw a clear line between them. It is a line built not of jargon, but of simple truths and human experience. The core of the confusion lies in shared symptoms. At times, a person in a manic episode of bipolar disorder might experience psychosis, hearing things grandiose beliefs. This can look, on the surface, like schizophrenia. Similarly, a person with schizophrenia can experience deep apathy, social withdrawal, which might be mistaken for the depression of bipolar disorder, but these are fleeting overlaps, not the defining nature of the illnesses. The fundamental difference is this: bipolar disorder is, at its heart, a disease of mood. Schizophrenia is a disease of thought and perception. One is a storm of emotion, the other is a fracture in reality. Understanding this distinction is not just an academic exercise, it is a matter of life and death. A wrong diagnosis can lead to the wrong treatment. The wrong treatment can lead to years of unnecessary suffering for both the individual and their family. It can lead to lost jobs, broken relationships, a deepening despair. Knowing the difference helps us offer the right kind of support. It allows us to speak with clarity and compassion. It empowers us to advocate for proper medical care. We must peel back the layers of myth and fear. We must look at these two distinct worlds with steady, informed eyes. This journey of understanding begins with simple definitions. Think of bipolar disorder as a pendulum of mood, swinging between extreme highs and devastating lows. One moment, a person might feel on top of the world, invincible, full of boundless energy. The next, they might be plunged into a dark abyss of hopelessness, unable to move, unable to think. Now, think of schizophrenia as a distortion of the senses and thoughts. The world is no longer perceived as it is. A person might see things that are not there. They might hear voices that no one else hears. Their thoughts may become jumbled, like a radio stuck between stations. These are not choices. These are symptoms of a brain-based illness. Section 2. The emotional roller coaster. Understanding bipolar disorder. Bipolar disorder is a condition of dramatic contrasts. It is defined by its two opposing poles: mania, depression. Mania is not just a good mood. It is a state of intense, often overwhelming energy and elevation. A person in a manic state might talk for hours, their words tumbling out faster than they can be followed. They might sleep for only an hour or two a night, yet feel completely rested and ready to conquer the world. This state is often accompanied by a feeling of grandiosity. They may feel they have a special mission, possess extraordinary talents. This can lead to impulsive and reckless behavior, spending sprees, risky business ventures, reckless driving. While mania might sound appealing, it is a dangerous and destructive force. It can shatter a person's finances, career, reputation in a matter of days. The high energy is not productive, it is chaotic and scattered. Judgment becomes severely impaired. A friend once described his mania as feeling like he had lightning in his veins, a power so immense, it felt like he could redesign the city overnight. He ended up emptying his bank account, buying hundreds of books on architecture, a subject he had never studied. The crash that followed was as severe as the high was intense, leaving him in a pile of debt shame. The other side of the coin is depression. This is not simple sadness. It is a profound and suffocating emptiness. The world loses its color. Food loses its taste. The simple act of getting out of bed can feel like an insurmountable task. There is a deep, bone-wearing fatigue that sleep does not touch. A person may lose all interest in hobbies, work, people they love. They may be consumed by feelings of worthlessness, guilt. Thoughts of death, thoughts of suicide are tragically common during these depressive episodes. It is a state of utter paralysis, a living death where the future seems like a blank wall. The cycle between these two states is the hallmark of bipolar disorder. Some people experience hypomania, a less severe form of mania that may feel productive and exciting but can still be a precursor to a full-blown manic or depressive episode. The length and frequency of these cycles vary greatly from person to person. For some, the shifts can happen rapidly, days, hours. For others, there might be long periods of stability, euthymia between episodes. Living with bipolar disorder is like navigating a sea with unpredictable weather. The goal of treatment is to calm the waters. Section 3. A different reality. Unpacking schizophrenia. Schizophrenia works differently. It does not primarily swing the pendulum of mood, it fundamentally alters the fabric of reality for the person experiencing it. The most widely known symptoms are called positive symptoms, not because they are good, but because they represent an addition to normal experience. These include hallucinations, which are sensory experiences without an external source. Auditory hallucinations, such as hearing voices. These voices might be critical commanding or simply a running commentary on the person's actions. A person might also see things, smell things, or feel sensations that are not there. These experiences are completely real to the person having them. Another key positive symptom is delusions. Delusions are firmly held false beliefs resistant to reason or evidence. They are not simply mistaken ideas, they are deeply ingrained convictions. A common type is persecutory delusions, where a person believes they are being spied on, followed, or plotted against. They might think the government is monitoring their thoughts through the television. Other delusions can be grandiose, where a person believes they have special powers or are a famous, historical figure. These beliefs shape their entire worldview and can cause significant distress and fear, leading them to isolate themselves for safety. Beyond these dramatic symptoms, schizophrenia also involves negative symptoms. These represent a reduction or absence of normal functions. A person may experience avolition, a severe lack of motivation to engage in purposeful activities. Their emotional expression may become flat or blunted, a condition known as affective flattening. Their face may seem unanimated, and their voice may be monotonous, even when discussing emotional topics. They may speak very little, a symptom called alogia. Social withdrawal is also common as the confusing inner world becomes more compelling and less frightening than the complex outer world. These negative symptoms are often more disabling in the long run than the positive ones. Finally, schizophrenia affects cognition, or the ability to think. This is often referred to as disorganized thinking. A person's thoughts may become jumbled and illogical. This can manifest in their speech, which might be difficult to follow, jumping from one unrelated topic to another, a word salad. They may have trouble with memory, attention, and executive functions, the mental skills that allow us to plan, organize, and solve problems. This cognitive impairment makes it extremely difficult to hold a job, manage finances, or maintain relationships. It is this combination of altered reality, diminished function, and disorganized thought that defines the experience of schizophrenia. Section 4. The roots of the storm. Causes and onset. Where do these powerful conditions begin? The timing of their arrival often provides the first clue. Bipolar disorder usually appears in the late teens or early 20s. Often the first episode is major depression. That can lead to misdiagnosis at first. The signature, manic or hypomanic episodes may not appear until later. Onset can be gradual or sudden, often triggered by major life stressors. Going to college, a relationship breakup, a significant loss. This timing makes the illness especially disruptive. Schizophrenia tends to emerge from the late teens to the early 30s. There's often a gender difference in onset. Men, late teens to early 20s. Women, late 20s to early 30s. Often there's a prodromal phase before the first psychotic episode. The person may become withdrawn, school performance may decline, work performance may decline, they may develop peculiar interests, they may have mild perceptual distortions. Family members notice changes but struggle to understand. Why it happens is complex. Genetics play a significant role. Having a close relative like a parent or sibling increases risk. But genes aren't the whole story. Many with a family history never develop the condition. Many who develop it have no known family history. This suggests an interplay between genetic vulnerability and environment. The brain's chemistry and structure are central to the puzzle. Imbalances in neurotransmitters are believed involved in both disorders. Environmental triggers can ignite a latent predisposition. Significant stress is a common trigger. Psychological stress from life events. Substance use. Sleep deprivation. For schizophrenia, researchers explore early life development, complications during pregnancy or birth, exposure to certain viruses in the womb, autoimmune diseases, mind-altering drugs during vulnerable teenage years can trigger psychosis and raise schizophrenia risk. Diagnosing these conditions not as simple as a blood test or a brain scan. It is a careful process of observation, conversation, and elimination. The journey to a correct diagnosis begins with a thorough clinical interview. A psychiatrist or psychologist will sit down with the person and, if possible, their family. They will ask detailed questions about the person's experiences. They will want to know about their moods, their thoughts, their sleep patterns, and their behavior. They will create a timeline of symptoms trying to understand when the changes began and how they have evolved over time. This history is the most critical piece of the diagnostic puzzle. The doctor's goal is to look for patterns. In the case of bipolar disorder, they are looking for distinct episodes of mania or hypomania and depression. The presence of even one clear manic episode is often sufficient for a diagnosis of bipolar I disorder. They will ask questions designed to uncover these highs. Under these osties. Have you ever had a period where you felt unusually energetic, slept very little, and took on big risks? For schizophrenia, the doctor is looking for the core symptoms of psychosis, such as hallucinations and delusions, as well as negative symptoms and cognitive symptoms. They need to determine that these symptoms have been present for a significant period, at least 6 months, and are causing major problems in the person's life. While there is no definitive biological test, doctors will often order medical tests to rule out other conditions that can mimic these psychiatric illnesses. A thyroid problem, for example, can cause mood swings that look like bipolar disorder. A brain tumor or certain types of epilepsy can cause psychotic symptoms. Therefore, blood tests, urine tests, and sometimes brain imaging scans like an MRI or CT scan are used. These tests do not diagnose schizophrenia or bipolar disorder, but they are an essential part of a careful and responsible diagnostic process. They help clear the path to a more certain conclusion. Ultimately, time is often the best diagnostician. The distinction between the two illnesses can be blurry at first, especially in a young person experiencing a first episode of psychosis. A doctor might make a provisional diagnosis and then observe the person's symptoms over several months. If the psychotic symptoms resolve, but the dramatic mood swings continue, the diagnosis is more likely to be bipolar disorder. If the thought disorder and negative symptoms persist even after the most acute psychosis has been treated, the diagnosis leans towards schizophrenia. This careful, longitudinal approach is crucial for getting the diagnosis right and setting the stage for the most effective treatment. Once a diagnosis is made, the focus shifts to treatment. While there are no cures for bipolar disorder or schizophrenia, there are highly effective treatments that can manage symptoms and allow individuals to lead fulfilling lives. The approaches, however, are quite different for each condition. For bipolar disorder, the cornerstone of treatment is mood-stabilizing medication. These drugs work to control the highs of mania and lift the lows of depression, creating a more even emotional keel. The classic mood stabilizer is lithium, a simple element that has been used for decades and remains one of the most effective treatments available. Other medications are also crucial. Anticonvulsant drugs, originally developed for epilepsy, have been found to have powerful mood-stabilizing properties. In some cases, antipsychotic medications may be used, particularly during acute manic episodes, to control psychosis and agitation. Antidepressants are sometimes used for the depressive phase, but they must be prescribed with extreme caution and usually in combination with a mood stabilizer, as they can potentially trigger a manic episode on their own. Alongside medication, psychotherapy is vital. Cognitive behavioral therapy, CBT, helps identify triggers, manage stress, and develop healthy coping strategies. Psychoeducation for the person and family is also key. The treatment for schizophrenia relies primarily on a different class of medications, antipsychotics. These drugs are most effective at reducing the positive symptoms like hallucinations and delusions. By blocking chemical pathways in the brain, they help bring a person back to shared reality. Newer atypical antipsychotics may have fewer side effects and can help with negative symptoms. Consistent adherence to medication is the single most important factor in preventing relapse. Missing even a few doses can lead to a return of symptoms. As with bipolar disorder, medication is only one part of a comprehensive treatment plan for schizophrenia. Psychosocial interventions are equally important. These include therapies that help with social skills, self-care, and daily functioning. Vocational rehabilitation can assist individuals in finding and keeping a job that matches their abilities. ACT teams provide intensive, round-the-clock community support. Family therapy and support reduce household stress and foster healing. The impact of these illnesses extends far beyond the mind, Both bipolar disorder and schizophrenia take a significant toll on physical health. People with these conditions have a shorter life expectancy than the general population, not just because of the risk of suicide, but also due to a higher prevalence of physical diseases. This connection between mental and physical health is profound and cannot be ignored. A major contributor to this is the side effects of some medications. For example, certain antipsychotic and mood-stabilizing drugs can cause significant weight gain and changes in metabolism, which dramatically increases the risk of developing type 2 diabetes and high cholesterol. This weight gain can create a vicious cycle. The physical changes can be distressing, worsening feelings of depression or low self-esteem. Furthermore, symptoms of the illnesses themselves can interfere with healthy habits. During a deep depression, a person may have no energy to exercise or prepare healthy meals. During a manic episode, they may be too agitated and distracted to eat properly. Similarly, the negative symptoms of schizophrenia, such as apathy and lack of motivation, make it incredibly difficult to engage in routine physical activity or maintain medical appointments. Substance use, which is common in both disorders as a form of self-medication, adds another layer of risk to physical health. Daily life looks very different depending on the illness and its severity. For a person with well-managed bipolar disorder, life between episodes can be completely normal. They can excel in demanding careers, maintain strong family ties, and pursue their passions. The challenge is managing the episodes when they occur. A manic episode can derail a career in an instant, while a depressive episode can make it impossible to function. Therefore, a structured life becomes a form of medicine. Regular sleep, a consistent daily routine, and stress management are essential tools for staying well. The goal is to live a full life, while always keeping a watchful eye on the early warning signs of a mood shift. For a person with schizophrenia, the challenges to daily life can be more constant. The cognitive and negative symptoms can make it difficult to navigate the complexities of work, school, and social relationships. Simple tasks like grocery shopping or using public transportation can feel overwhelming. However, this does not mean a meaningful life is out of reach. With consistent treatment and strong support systems, many people with schizophrenia live independently, work in supported employment, and enjoy rich social lives. The focus is often on recovery, which means learning to live well with the symptoms that remain. It's about finding purpose, connection, and hope, even within the constraints of the illness. In the quest to better understand and treat these complex illnesses, technology is opening up new frontiers. Artificial intelligence (AI) digital tools are beginning to offer powerful new ways to diagnose, monitor, support individuals. For instance, AI algorithms can analyze patterns in a person's speech writing. By detecting subtle shifts in language complexity, tone, pace, these tools could one day provide early warnings of an impending manic episode, psychotic episode. This would allow for proactive intervention before a full-blown crisis occurs, potentially preventing hospitalizations and severe disruption to a person's life. Technology also plays a role in how we visualize and explain these conditions to the public. When creating educational materials, news reports, AI can help producers quickly sort through vast libraries of stock video clips and images. An AI tool could be asked to find a clip representing social withdrawal or an image that evokes a feeling of confusion. This helps create more accurate and empathetic media portrayals, moving away from harmful stereotypes. By using carefully selected visuals, we can better communicate the internal experience of these disorders, fostering greater understanding and reducing the stigma that so often surrounds them. Digital health tools such as smartphone apps are also becoming an important part of daily management. There are apps that help individuals track their moods, monitor their sleep, remember to take their medication. These apps can collect data that can be shared with a doctor, providing a much more detailed picture of a person's condition than what can be recalled in a brief office visit. Telepsychiatry, which uses video calls to connect patients with mental health professionals, is another vital technological advance. It breaks down barriers of distance mobility, making it easier for people in rural areas or those with severe symptoms to access consistent care. Issues of data privacy and the potential for algorithmic bias must be carefully managed as these technologies become more widespread. The promise of technology lies in its ability to augment, not replace, the human element of care. It is a powerful new instrument in our orchestra of treatment, but the conductor must always be human. The journey through the worlds of bipolar disorder and schizophrenia can be daunting, but remember, these are treatable medical conditions. The most important differences to hold on to are clear. Bipolar disorder is a disease of mood, extreme highs, extreme lows. Schizophrenia is a disease of thought, a break with reality. One is an emotional storm, the other is a perceptual shift. Knowing this difference is the first step toward treatment and stability. Both conditions are serious, deserve our compassion, and respect can be managed with the right care. If you recognize these symptoms in yourself or someone you love, seek help. Do not wait for the storm to become a hurricane. Make an appointment with a doctor or a mental health professional. Be honest and detailed about what you are experiencing. Write down your symptoms, your sleep patterns, any major life changes. Ask for a thorough evaluation to rule out other medical causes. A proper diagnosis is the key that unlocks the door to effective treatment. Early intervention improves long-term outcomes and can prevent years of pain and loss. Support is not just a comforting idea, it is a clinical necessity. For those navigating these illnesses, a network of support from family and friends is invaluable. Loved ones can help by learning the facts, encouraging treatment adherence, providing a stable, non-judgmental environment. They can help with practical things like keeping appointments, managing routines. Most importantly, they can offer the steady presence of love and belief in recovery. Support groups for individuals, support groups for families, connecting people with others who truly understand the journey. There is every reason for hope. Decades of research have given us medications that can calm the storms, medications that can clear the fog. Therapies can equip individuals with the skills to navigate their lives successfully. New technologies are making care more accessible and personalized. Recovery is not a distant dream, it is a daily reality for millions of people. It means living a life of purpose and meaning, with or without some persistent symptoms. The path forward is built one step at a time, with courage, with treatment, with unwavering support. You do not have to walk this path alone. The first step is simply to ask for a hand to hold.